So, GERD is a syndrome, a backwards flow of gastric contents into the esophagus, causes heartburn, regurgitation syndrome, asymptomatic or inflammatory. You have a wide range, affects 10 to 20% of adults, around 15 million people. One of the most common digestive disorders in children. No one single cause. Esophageal irritation and inflammation. Degree depends on the amount. Causes mucosal damage from the reflux of the stomach acid into the lower esophagus. Not really a disease, more of a syndrome. The reflux of that gastric acid kind of overflows and overwhelms the esophageal defense systems. Gastric acid and pepsin secretions are the main cause. A lower esophageal sphincter incompetence is one cause of the sphincter, which normally is shut and acts as the anti-reflux barrier, doesn't do its job, and it opens up and allows the gastric contents into the esophagus. Obesity is a risk factor for LES incompetence, also smoking, nicotine, pressure. Etiology, symptoms vary person to person, mild to severe. Heartburn is the most common symptom. Risk factors, certain body positions, pressure from obesity, tight clothing, excessive alcohol, smoking, hiatal hernia, pregnancy. The LES dysfunction is one of the major causes there. Pathophysiology, the anti-reflux barrier. Sphincter does not do its job. Pressure differences between the stomach and the esophagus are usually keep that sphincter closed, but it doesn't work in this case. And it results in this reflux. Classic manifestations, you'll complain of mild symptoms 2 times a week or moderate to severe symptoms once a week. Heartburn, most common symptom, burning, tight sensation in the lower sternum, sometimes spreads to the jaw or throat, felt intermittently. Heartburn may be experienced after eating foods that decrease the pressure. Evaluate especially severe symptoms are happening, or if they're being awakened at night from sleep due to symptoms. The dyspepsia symptoms are persistent indigestion, pain, discomfort in the upper abdomen. Discomfort is felt mainly around the midline. Regurgitation, hot and bitter, sour liquid, great after lunch, comes into the mouth or throat. Hypersalivation. They may also have respiratory symptoms such as wheezing, cough, shortness of breath, otolaryngological pain, jaw pain, hoarseness, choking sensation, sense of a lump in their throat, and sleep disturbances that will wake them up during the night with symptoms. GERD-related chest pain can mimic angina. Burning, squeezing, radiating to the back or jaw or arms. Complaint of chest pain, common in older adults. Rule out cardio first and other factors. The hallmark sign is that this pain is relieved with antacids, whereas cardiovascular chest pain is not. Complications, esophagitis. All the complications are due to direct local effects of the acid on the esophageal mucosa. Esophagitis long-term may lead to skin, scar tissue, strictures, dysphagia. Barrett's esophagus is a metaplasm. It's a reversal. It's reversible, but it's a change from one type of cell to another type because of the abnormal stimuli. In this case, the squamous cells and the epithelium change to columnar. epithelium. It's a precancerous lesion. It's diagnosed in 5 to 15% of patients with chronic reflux. Must be monitored every 2 to 3 years, endoscopy for return. Complications: cough, bronchospasm, laryngeal spasm, laryngeal spasm, the cricopharyngeal spasm, dental complications, teeth erosion, especially in the posterior teeth, get acid reflux in the mouth, asthma, chronic bronchitis, pneumonia from aspiration, and so they do suffer respiratory problems. Diagnostic studies: physical and history of physical, radionuclide tests, esophagogastroduodenoscopy, say that 10 times fast, barium swallow, Bernstein test, 24-hour ambulation pH monitoring. This one, there is a sensor that's put in the esophagus, and it will later be eliminated through the bowels, and it will give an idea of how much acid is being produced. So the diagnosis is based on symptoms, also biopsies and cytology analysis, especially for cancer or for Barrett's syndrome. Pharmacological therapy: acid protective, such as Carafate to protect the mucosa, forms a protective layer. Other cholinergics, such as phenolcholine or bethacholine, for help with the LES pressure, improve the esophageal emptying, increase gastric emptying. So drug therapy for GERD focuses mainly on decreasing the volume and the acidity of the reflux, improving the LES function, LES, increasing esophageal clearance, and protecting the esophageal mucosa. The protokinetic drugs help with gastric emptying, like Reglan. They reduce the risk of GERD, not for long-term use. Antacids are short relief, mild symptoms. They neutralize the acid. They're best if taken 1 to 3 hours after a meal and at bedtime. These include the Melantas, the Rolaids, the Tums, Alka-Seltzers, all those. Proton pump inhibitors, PPIs, the result of Prazole.
What is the LES for?
So the LES is the lower esophageal sphincter. It's at the very top of the stomach, at the bottom of the esophagus, the LES. But it's the lower esophageal sphincter.
I just didn't know what it stood for.
That's fine. I'm sorry? Any other questions? Okay, so we're on to the proton pump inhibitors. They are the most common and effective treatments that are given. They're the most common and frequent. They promote, because they, in addition to decreasing the acid, they also help with the healing process of the esophagus. Okay, where was I? So the proton pump inhibitors, they block the acid they produce, that's produced, and they aid in the healing. Most common side effect is headache, Histamine 2 blockers decrease acid as well, decrease the symptoms and promote healing. These are the Zantac, Tagamet. The PPIs are more effective for esophageal healing actually than the histamine 2 receptor blockers. They're given once a day. Side effects are long-term, such as increased or decreased bone density, kidney disease, B12 and magnesium deficiencies, and an increased risk of dementia. They also have an increased risk for hip fractures, C. difficile infection and in hospitalization or hospitalized patients, and elevated gastric pH. They increase the risk of pneumonia, especially what happens is it gets